Hiya, my name's Alice. I'm one of the anaesthetic ST3s, and we're just going to run you through a scenario on an unwell patient in an A to E fashion.
My name is Amin, I'm one of the ITU doctors, and I'm going to be enacting the scenario.
And we've got Dev, who's going to be our nurse in the scenario as well. So in a minute I'm going to do a handover to Amin, and he's going to start assessing the patient. So, Amin, it's Saturday morning at 9 o'clock on the gastro ward, and you are the Foundation Year 1 who's been called by the nurse. She tells you that there is a 56-year-old female admitted for alcohol withdrawal seizures. We've had 100 ml of fresh blood-stained vomit. This is the second episode in the last 4 hours. Apparently the nurse asked the night staff to hand it over, but they haven't. Bloods were sent earlier in the evening, including a cross-match, and the patient has one IV access with a pink cannula. You ask for the observations over the phone, and she tells you that the respiratory rate was 22, the SATs were 96% on air, the heart rate was 107, the blood pressure was 103/70, and the temperature is 36.5. And she's asking you to go and see the patient.
Okay, fine. So I'm just going to go up to the patient on the ward to introduce myself. So hi, my name is Amin, I'm one of the ITU doctors. How are you doing?
Yeah, I'm alright. I'm just feeling a bit sick and I've got some stomach pain.
Okay, can I just confirm that your name is Jamie Smith?
Yeah, that's me.
Okay, perfect. So Jamie, I'm just going to ask you a few questions to see how you're doing and then examine you if that's okay. So can you tell me more about this pain?
So it's just sort of right in my upper stomach. I've had it for the last sort of 24 hours, but I think it's getting worse.
Okay, and you're vomiting as well, is that correct?
Yeah, I've just had a couple in the last sort of couple of hours.
Okay, and has there been anything unusual there, like blood?
The nurse said she thought it looked like it had some blood in it when she took it away from me. Yeah.
Okay, fine. And is it just the last 2 times that you've had blood there?
Yeah.
Okay, fine. Just going to ask you a few more questions about your medical history. Do you know what medical problems you've been diagnosed with?
I've got some liver problems from my drinking problem, but other than that I'm fit and well.
Okay, and do you drink quite heavily?
Drink about a litre of vodka a day, and sometimes a couple of cider or beers on top of that.
Okay, fine. And do you take any regular medications?
Just the vitamins and minerals they usually put you on for alcohol stuff.
Okay. Are you allergic to anything?
No.
Okay, fine. Are you on any blood thinning medications?
No.
Okay, fine. So I'm just going to do a few more checks, get the nurse to do a few checks as well, and then I'll come back and examine you if that's okay.
Yeah.
So hi nurse, my name's Amin, I'm one of the doctors here. Would it be possible to get some up-to-date observations on this patient?
Sure.
So Jamie, I'm just going to examine you. So I'm going to start by talking out loud and talking about my findings, so just ignore me when I do that. So I'm going to examine this patient by an A2E approach. So starting with the airway, I can see that the patient's airway is intact because they're speaking full sentences. Moving on to assess their breathing. I'm going to first of all observe by the bedside. I can see that the patient's not in any respiratory distress. There's good air entry. There's good chest movements bilaterally, equal expansion. Going on to assess that further, I'm just going to put my hands around your chest for a moment. So I can see chest expansion is good. And percussion is good bilaterally. Chest is clear with good air entry bilaterally. Okay, fine. So I can see that the patient's hypotensive. So just to complete my examination of the circulation now, I can feel the peripheries are warm and well perfused at this point in time. The capillary refill time centrally. If I press down on the chest for a few seconds, just over the sternum, once I remove my fingers, I'm going to count the seconds it takes for the current to return to normal, and that in this case is 1, 2, 3 seconds. blood pressure I can see is low at this point. I'm going to, because the patient's unwell, I'm going to start my interventions as I go through with the assessment. So at this point in time, I'm going to ask the nurse if they could kindly put in some cannulae. So if I could get 2 large block cannulae, one in each antecubital fossa. With the first one, if you could take bloods as well. So if you could send off a VBG, cross-match 2 units, a full blood count using these and LFTs as well, please. In the second cannula, I'd like to get some fluids going through to help reduce blood pressure. So I'd like 1 litre of Hartmann's to go through via the second cannula. Okay. Just going back to the airway, I can see even though the patient's airway is fine, there's no specific breathing issues at present. Because there's an unwell patient, with anyone in this situation, we're going to give them 15 litres of oxygen by non-rebreathe mask. Okay. I'm just going to continue with my assessment as well. So moving on to D, the GCS for this patient is 15, as I established with the history. Patient's glucose would be good to know, so you can see that we're giving the VBG, so we can find out from that. Moving on to exposure, I'd like to adequately expose the patient.
Check that, that's Hartmann's 1 litre.
Yeah, thanks. So moving on to expose the patient, I'm going to, with the help of my chaperone, look to see if I'm missing anything that could be suspicious. So Jamie, I'm just going to have a look under the sheet.
And as you take that off, you see 200 mils of melina in the bed there.
Okay, fine. So that's important to note that there's melina under the patient's bed sheet, 200 mils. For the rest of my exposure examination, I'm going to have a look at the abdomen. So, looking carefully at the abdomen, I'm going to then palpate. So, Jamie, I'm going to have a feel of your tummy. Let me know if there's any pain when I press down.
Not too bad. Oh yeah, that really hurts. That really hurts too. Oh yeah. Not too bad there.
The tummy is soft, but I can see that there's epigastric tenderness on palpation. And listening for bowel sounds.
Bowel sounds are sluggish.
Sorry?
Bowel sounds are sluggish.
Bowel sounds are sluggish. Okay. So at this point in time, I'm going to reassess the patient before we need to approach again. So Jamie, can you hear me?
Yeah, I can.
Fine.
I feel a bit sick.
Okay, so we're going to give you something for that in a moment. I'm just going to go through the examination again. Okay, so you can see the airway is still patent. Patient saturation's 95% on 15 litres. I have no concerns with the patient's breathing. With the circulation, the patient's capillary refill time was prolonged. The patient's hypotensive. We've got some fluids running, which will hopefully try and correct that. We've got some investigations being sent off in the form of bloods and cross-match as well. Moving on to the rest of the examination, the patient's abdomen was tender and there was a pool of blood, melina, around the bedside, about 200 mils. So at this point in time, I would like to give the patient, have a look at the patient's records, look at their drug card, just to make sure I'm not missing anything there.
What are you looking for on the drug card, Anna?
So specifically, I'm looking for any anticoagulation and any antiplatelet agents which may have contributed to this bleed. And from the drug card, I can see that the patient is only on vitamins and omeprazole. I'd like to prescribe this patient some omeprazole now in form of IV omeprazole, 40 milligrams.
Okay.
And possibly some antiemetics for this patient as well, seeing if he's sick. I'd also consider some analgesia as well. Now that I've done that, I would like to speak to a senior colleague of mine, so I'd like to call my medical registrar. So I'm going to go over to the phone and bleep them.
Please enter user number.
You then enter the patient's bleep, not the patient, the doctor's bleep. So in this case it would be 890. After that's done, you'd enter the 4-digit number for this phone, which in this case is 76759. So once that's done, I wait for the patient for the doctor's response. Hello?
Hi there, can I see the med reg?
Hi, it's Amin. I'm one of the foundation doctors. I've just come to see an unwell patient. Is it okay if I tell you about them?
Yeah, that's fine, sure.
So I've got a 56-year-old lady, Jamie Smith, who was admitted with abdominal pain and vomiting. I've come to see her because she's had a massive GI bleed. She was quite unstable. When I approached her, I found her to have an intact airway, no breathing issues, but with her circulation she was hypotensive with a prolonged capillary refill time. She's got a GCS of 15, she's got an abdominal tenderness epigastrically, as well as pooling of melena by her bedside, about 200 mils. So far, I've started her on 15 litres of oxygen via non-rebreathe mask. We've got 2 large bowel cannula in the antecubital foci. We've started fluids, 1 litre of Hartmann's running through, and sent off bloods cross-matching a VPG. The patient's mu score is currently a 5. I've prescribed some omeprazole intravenously and some antiemetics for the time being as well. Is there anything you'd like me to do for the time being?
First of all, thank you. That sounds like excellent management. So what I'd like you to do is list the patient for an urgent endoscopy via portal, and also if you wouldn't mind getting the patient catheterized and starting the fluid balance, and then I'll come in with you.
Okay, I will do. Thank you.
Thank you.
Bye. So that's the initial management from a foundation doctor's point of view. I've escalated for help. The other things I could probably do now is just have a thorough look at their previous records as well.
Good. Well done, thank you very much. So that was a beautiful example of a very slick and detailed A2E assessment and management of a GI bleed. So Amin did everything very well and thoroughly and responded to the signs that he was getting as he was going through, and he made sure that he kept reassessing the patient every time he did an intervention to make sure there was nothing that was changing as we were progressing through the scenario. He correctly identified a sick patient, he correctly identified the diagnosis and started appropriate management for the patient, and then recognising the patient was sick, he also called for a senior backup and handed over in a very beautiful S-bar handover, and got some further management plans from the medical registrar on call. The only other things to mention with before you leave the patient bedside after you've completed all the jobs is just to make sure that the nursing staff know exactly what they need to do. So ask them to do a fluid balance chart, how often you want your observations being done, and then to just document very thoroughly in the notes. So everything that you found, everything that you did, and then the management plans going forward and handing over to the appropriate teams. We have a urgent bleeders list here, which is booked via portal, and it's an endoscopy for people who are having GI bleeds that usually get done the next day or if not the day after. If you think that the patient needs to be in a high observation area, then the best thing to do is talk to the med reg and the site matron, who might be able to move them to a more appropriate place if you think that they're very sick. And if in any doubt, if you think the blood loss is over a litre, then you can always activate the major hemorrhage protocol, which you do via 2222, and you just say code red, which activates a whole team of people and a porter and lets the blood bank know that we need some urgent O negative blood, who will then talk to you further about what your products need as it progresses. The only other thing to mention, obviously, with liver patients, we had an alcohol history, is just check their coagulation, because obviously they're often coagulopathic, so early discussions with the haematologists and discussing different blood products and replacing things as necessary.